Thanks very much for inviting me. I feel like a bit of an imposter. I'm not an infection prevention specialist. I'm a chest physician. I work at the acute hospitals in Liverpool, and my clinical focus is all respiratory infections. So I run a bronchiectasis clinic. I'm the TB lead for our hospital. But my substantive employer is the university, and they employ me as an academic to study infection, and my focus is pneumonia. And in the past, I have mainly focused on community-acquired pneumonia. But when I was appointed as a consultant, it became clear that we had a huge problem with hospital-acquired pneumonia. We make the diagnosis very frequently. We use challenging antibiotics for that, and patients seem to die quite a lot. And so we embarked on a research program to try and tackle hospital-acquired pneumonia. It's that I'm going to try and tell you about today. I should say at the beginning that the evidence base for the management and how we understand hospital-acquired pneumonia is very poor. To give you an example of that, NICE wrote their prescribing guidelines in 2019 for hospital-acquired pneumonia. They looked at, I think, 16 randomized controlled trials that met their criteria for quality. And of those randomized controlled trials, only one recruited patients from the UK. And that trial had 10 patients from the UK. So when we manage HAP in the UK, our entire evidence base for how we prescribe antibiotics and manage it is based on 10 people from the UK. And most of those patients were recruited in the US or in Southern Europe, like Greece, or in China, where the antibiogram is very different from the pathogens that cause our hospital-acquired pneumonia in the UK. So filling the evidence gap is, well, it's good. Not many people have done much work in that area, so it gives me lots of targets, but we don't have a lot of basic information. So what I'll talk about today is the status quo, where I think we were, maybe around 2017, in terms of what we know about HAP, what we've done in the Northwest to try and build a very basic evidence base about who these patients are, how they present, where they are in our hospitals. Then we'll start to talk about some of the insights that we've gained from that data that we've been collecting for the past few years. And then finally, I'll talk about what I think all that data on our cases means for prevention and how we might think about preventing this condition going forward. So the status quo, so many of you will be familiar with this plot. This is based on point prevalence surveys done across Europe, trying to measure the rates of different hospital-acquired infections. So the most common hospital-acquired infection syndromes are plotted here, and across your x-axis, you've got the number of cases per year, and up the y-axis, you've got the number of deaths. And then the size of the blobs is what's called disability-adjusted life years. So these are people who don't die, but are harmed and have a range of different morbidities associated with that condition, like loss of independent living, resilience on children, etc., and carers to help them at home, and more contacts with the NHS. So what you can see from this plot is that hospital-acquired pneumonia looks like it's one of the biggies. There's a large number of cases. It's way up there on the x-axis. There seem to be a lot of deaths associated with it, more possibly than any of the other hospital-acquired infection syndromes. And the size of the blob is the greatest. So more morbidity, more harm caused by this in people who survive than any others. So it certainly appears in point prevalence surveys, with all their limitations, like this is a big condition. And yet, compared to many other hospital-acquired infections, we have no organized policy in the UK about this, nor in most hospitals. We don't have regular surveillance, and back in 2016, 2017, and ever since, if you're a pneumonia geek like me, the pneumonia literature is full of people arguing that we should be having an ongoing organized surveillance program for HAP to try and understand our cases, where they are, and try and improve quality. This happens in many US hospitals, largely driven by financial expectations and choice of quality hospital you might want to go to if you have an elective admission. And I think it's coming in the UK, but people have been arguing for that ever since. Because these point prevalence surveys really don't tell us a lot of detailed information about our patients. So what we've done in the Northwest, along with a quality improvement organization called the Advancing Quality Alliance, is an initial pilot project using 15 or so hospitals who agreed to collaborate and share their data and try and capture an understanding about the characteristics of their patients who had HAP in their hospitals. And this is the sort of thing that we learned. The first thing we learn is that in our hospitals, we very certainly have a lot of cases. Because if we take our patients who are coded as HAP, so that is to say they leave hospital or their admission is completed with a J code for pneumonia followed by a Y95 code for a nosocomial infection, there's a large number. And if you then validate them to exclude people who in actual fact have probably been miscoded, you still stick with a very large number. My hospital's in red, that's the Liverpool University Hospital Foundation Trust. There's 2 big acute hospitals there. And these numbers suggest that we're running at about 11 to 1,200 cases of HAP a year. So a bit more than the number of cases of community-acquired pneumonia that we have. So certainly we have a lot of cases. If you look at the outcomes of these patients and their characteristics, they tend to be older, as you might expect, than patients with community-acquired pneumonia. Disappointingly, a large number of cases of HAP occur in people who are medically fit for discharge. Consistently, it looks like about 12% of people who are coded of having an episode of HAP develop that at the point at which their acute admission or their elective admission, whatever they went into hospital for, has been solved. They're waiting to get home. They're waiting for placement in nursing home care or, toilet to be put in at home or something, and then they get HAP. And that's a real problem when you look at the outcomes. An interesting fact we discovered in our pilot is that if you look at the day of a patient's admission on which they're diagnosed with HAP, although you can be diagnosed with HAP on any day, even right up to many hundreds of days that some people have in hospital for very complex admissions, the single most common day to be diagnosed with hospital-acquired pneumonia is day 0 of your admission. That is to say, on admission in A&E. That seems really paradoxical to some people because a lot of people have had this sort of, have been told that HAP is something that only occurs 48 hours after you've been admitted to hospital. But there is a caveat to that. So the caveat is that in 2009, when the British Thoracic Society wrote their guidelines for the management of community-acquired pneumonia, they wrote that this guideline for CAP, for pneumonia, doesn't apply to people who presented to hospital in the last 10 days, who've been in hospital rather, within the last 10 days. So if you go in for an elective hernia repair, spend some days in hospital, go home, but then come in with pneumonia within 10 days of having gone home from your previous admission, that pneumonia should, according to the BTS, be managed as HAP. The FDA in the US agree with that in their guidelines for running trials of HAP. They say if you've been in hospital within the last 7 days, that counts as a case of HAP. And so the consequence of that is that our very large number of patients who come in and out of hospital, when they present to hospital with pneumonia, if they've recently been discharged, they are diagnosed with HAP. So that has implications for moving forward because if we're going to plan interventions, we can't simply focus on the back of the hospital, on the wards. We're going to need to have a significant focus in the acute care areas. Where are the rest of these patients? Well, they're spread throughout the entire hospital. Every single ward in every single hospital that participated in our pilot had cases, even those with carpet, even the private wards, there were cases there. There were big spikes in certain areas, so not unsurprisingly, there was a big spike in the surgical unit, as well as the care of the elderly units, etc., etc. So if you're thinking about how you were going to be savvy about implementing interventions, you've got a challenge because you have to implement them across the whole hospital, but there are certainly spikes in certain areas. It's a really severe condition. So in-hospital mortality in our pilot survey was 23%. So in-hospital mortality for an ST elevation myocardial infarction in the UK is about 9%, for strokes about 12%. So this is much higher than a heart attack, much higher than a stroke, much higher than trauma, and much higher than community-acquired pneumonia. So it's a bad thing to happen to you. And you're very likely to be readmitted. Lots of people get readmitted within 30 days following community-acquired pneumonia, but even more people get readmitted following HAP. So it looked to us like the outcomes following HAP were severe, and it looked like we definitely agreed with the point prevalence surveys that we have a lot of cases in the Northwest. Some people are critical of data and trials suggesting that outcomes are severe in HAP because they say, all right, you tell me that 23% of people die in hospital following HAP, but they went into hospital for something else. You know, if they've gone into hospital because they've fallen and fractured their hip, surely their admission diagnosis contributes significantly to that mortality. That mortality is surely not all to do with the pneumonia. So we've looked at that. We've looked to try and tease out what is the attributable adverse outcomes to HAP as opposed to the other conditions. So we've done, based on the data that we've collected since then, this case control piece of work, which if any of you are at ECCMID next weekend, we're going to present. So what we've tried to do here, starting from the top, is take 828 cases of validated hospital-acquired pneumonia in the northwest of England cohort and match them with 828 patients who didn't have an episode of hospital-acquired pneumonia. And we've tried to be quite systematic with our matching. So we've picked out cases that presented to the same ward within 5 days of the case. And we've matched them for their age. So the mean age in both groups is 76. And then within each age category, so the 20 to 30, 30 to 40, 40 to 50-year-olds, we've matched them. So we've got the same profile of age in the patients. We've matched them for a couple of key comorbidities, so same number of people with COPD in both groups, same number of people with other respiratory conditions in both groups. We've matched them for whether or not they had an elective admission or not, so they went in for planned surgery, so the same proportion in each group. And then within the non-elective emergency admissions, we've tried to match the two groups for why they went into hospital. So we've got the same number of people with stroke, COVID, sepsis, heart failure, neck edema in each group. So let's look at the outcomes. So in the cases, mortality in hospital looked like the same as in our pilot study, 22%, which is roughly double that of people who didn't have HAP. Length of stay seemed to triple. So on average, the non-cases stayed in hospital for about a week, whereas the cases were staying in hospital for 3 weeks. So this looked to us like HAP was having a very significant impact on a patient's outcome. Tripled length of stay and doubled your mortality. So based on that pilot data, what we've tried to do is to gain some insights further into our patients and to try and extrapolate that to what it might mean for the UK. So if we're going to argue to policymakers that we need a surveillance program nationally, how are we going to convince them that there's actually a problem to address and that the scale of this problem matters throughout the UK? All right, we've done our parochial piece of work in the Northwest, but what about the rest of the UK? Well, when we look at discharge coding throughout the UK and standard NHS data and extrapolate up the figures that we've got from the Northwest, we estimate that there are about 75,000 cases. We think that's quite a conservative estimate of HAP in the UK. Based on a sort of mid-range estimate of the excess length of stay associated with HAP. So we used 9 days as opposed to more like 14 or 20 days that we saw in that case control study. That would suggest that there's about 459,000 excess bed days associated with HAP in the UK. I haven't put the number there, but on average, a UK acute bed day costs about £300 to £500. So if you multiply, you put 2 noughts on the end of that and multiply it by 3, you end up with a very large amount of money that seems to be costing these excess bed days in hospital. And that's about 15,000 deaths in the UK. So we're trying to argue with NHS England and policymakers that we think this is a fairly large England-wide impact. What we've done next is to look a bit further and look to see, is the epidemiology of HAP static or is it changing over years? Are our data that we've collected so far a bit of an anomaly or are they consistent across years? So going back about 4 or 5 years, we see that there are relatively consistent incidence rates of coding of HAP throughout England across this period of time. But there is considerable variation in incidence throughout the UK. So in where I practice, in my part of the world, we have the highest incidence of this condition anywhere in the UK. Some parts have very considerably fewer cases of HAP. And that's interesting. I don't have the answer to that. It's probably related to some case mix factors, rates of socioeconomic deprivation, rates of certain comorbidities. It's probably also related to system factors. There's some good evidence that the number of nurses on your ward significantly influences the proportion of cases of HAP that you might have on that ward, and some hospitals run more nurses than others on their acute wards. What is telling about this is it means that there's room for manoeuvre, there's room for intervention. Where you have variation in care, there are interventions that we could potentially target in certain parts of the country to try and reduce the incidence. So what does all this mean for prevention? It looks like we've got a lot of cases, looks like this condition has a very major impact, and it looks like regionally there's significant variation. The sort of conceptual models that have been built around prevention of hospital-acquired pneumonia are really well summarized, I think, here. This is from an American academic nursing group who've tried to think about, if we're going to put bundles of care into place and start to plan research around HAP, what are the sort of mechanisms that we need to target? So they've worked backwards and they've said, well, if you want to prevent HAP, you need to think about reducing colonization in the mouth. So this conceptual model is very heavily focused around the concept of aspirating your mouth and pharyngeal contents into your lung. They think, the literature suggests, that's how you get HAP. And so you can work backwards from that and you can say, well, if that's how it happens, then what are the interventions we need to put into place? Well, we need to think about oral hygiene. We need to think about brushing patients' teeth or encouraging to brush their teeth, using things like chlorhexidine, etc. These are very simple things, but very challenging for a workforce that is really hard-pressed and doesn't have a lot of time to do anything extra. We need to do more swallow assessments, they think, to spot people who have got swallowing difficulties so they don't aspirate. We need to elevate the head of the bed so we don't nurse people lying flat. We need to mobilize people early so that they open up their lungs and clear the secretions. We need to make sure they're well nourished, and we need to think about maybe not prescribing so many PPIs, they suggest. I think that's a particularly interesting thing that we could potentially come back to. What I would say to you is that this slide is dominated by the concept of HAP being a bacterial disease. I'm not totally convinced by that. I'm sure some people very definitely have a bacterial pneumonia, but a very large proportion of people, I think, have a virally driven nosocomial infection. We saw in COVID, and we see every year when there is a flu epidemic, that we have lots of nosocomial spread of virus, either brought in externally by little Johnny who comes to visit his grandmum who's just had a hip done and he's coughing and he's got flu and he gives it to granny, or from staff or from patient to patients on the ward. And the more molecular testing we do, the more we find that people that we're labeling with HAP actually have a virally driven condition. So I think one thing that's missing from this sort of conceptual model is a real focus on how we prevent nosocomial and viral infection. And you can pick any particular viral pathogen that you choose, and you see very high rates of nosocomial spread while a particular virus is prominent in the community. If you're going to think about prevention strategies such as bundles suggested by that conceptual model, like oral hygiene and swallow assessments, you might want to think that rather than implementing it across the entire hospital bed base, you could target it on certain patient groups that are at particular increased risk. And I think that means understanding which patients with which conditions are at particular greatest risk. So if you look at standard NHS coding data and then burrow down into what the original reason for admission is, and we've used that in our NHS data set that we've got now from the Northwest, you find that particular elective conditions are very strongly associated with HAP. So what we've got here is just the major NHS coding chapters of disease. And you see that people with lower digestive system elective admissions, so lower GI surgery, account for the largest proportion of all cases of people who develop HAP following elective admission. Upper GI surgery is the next big group, then other bone and joint surgery, etc. So you have just a few groups of elective surgical admissions who are dominating and responsible for the majority of cases. But the devil is in the detail. So if you open up Chapter H, that was lower digestive system cases, there's about 50 different subcategories of why you might go into hospital for an elective lower GI procedure. And some of those categories are associated with no cases of HAP at all. Of course they're not. So if you go in for a colonoscopy, you don't stay overnight, you don't get HAP. But some of these particular conditions totally dominate and are responsible for very high rates. So if you go in for an anterior resection, your risk of getting HAP is very high. So this starts to take us towards a situation where you can pick particular groups of patients and say, this is the one where we really need to put our bundle in place. And you can get down to being as sophisticated as individual procedures. When you look at emergency admissions, the same thing applies. So if you look at which conditions a patient comes into hospital with as an emergency admission and then is most likely to develop HAP, you see that going into hospital because of cancer has the highest rate of HAP associated with it, higher than anything else. So you can start to imagine a scenario where you see people in the acute admission unit, they've come in because of a new big lump in their chest, you think they've got a lung cancer, you need to be really worried that they're going to develop HAP. You can flip that around and you can say, well, okay, certain conditions have very high absolute rates, but what about the numbers? Well, it looks like, although the absolute rate for people with injuries, so trauma, is not quite as high as cancer, because we have so much trauma and so many injuries presenting to hospital, actually, in terms of the absolute numbers, injury and poisoning is the single commonest condition that eventually results in a case of HAP. So these are ways of using the data that we're now acquiring to understand in a much more sophisticated way who is at risk of HAP and where can we target our interventions. I'm getting towards the end now. The final thing I would say, and I think it's been said in earlier cases, is that we need to think much more carefully about multimorbidity. So if you simply put a count of the number of discharge ICD-10 codes that a patient has relating to their different comorbidities, hypertension, chronic renal failure, COPD, etc., you see that the more conditions a patient comes in with on their list of comorbidities, there's a linear relationship between that and rates of HAP. So you can build that into your predictive models and say, here's a patient with lots of comorbidities, they've come in for an anterior resection, this is a person who's at really very significant risk of HAP, and that's where you need to start targeting your intervention. And Jenny Wilson and her group have done a brilliant piece of work published last year that has started to build these sorts of factors into a personalized risk prediction model. This is really where I think we need to be moving. This is just one key table from her paper that shows that if you look at many different things from the literature that might support risk of HAP, and then you do some multilinear modeling to try and understand which of those really come out as key drivers, you find that having an oral care management plan, so needing oral health care is a big predictor. Being fully independent with your mobility predicts not getting HAP, but being dependent for your mobility puts you at major risk, et cetera, et cetera. And what I like about this model is that it's very holistic. Not only does it include comorbidities, so you've got cognitive impairment, respiratory disease, and heart failure there. You've got some drugs that are key drivers that we can focus on in our prescribing. We've got their past medical history. Have they had a pneumonia before? If they have, that puts them at significant risk of having another one. So based on putting this sort of data into their risk model, you can predict people who are more or less likely to have HAP. And you can target your interventions based on which of these drivers they have. So to summarize, I don't think I've said anything very sophisticated other than we've got lots of HAP. We definitely have. It kills a lot of patients. 1 in 4 people who come into hospital who develop HAP die in hospital. And it has a huge impact on the NHS. Huge number of excess bed days, huge cost. That's just the direct in-hospital NHS costs. All these people with their morbidity following HAP put a huge burden on social care. We have no national surveillance so far, but I think it's possible. We've shown in the Northwest that you can collaborate as hospitals to share data and understand your case mix and start to plan where the risk and where the intervention should be. HAP prevention thinking at the moment is really not complex. I didn't show you anything on that conceptual model that was very sophisticated. It was nursing people at the right angle, brushing people's teeth, getting them up and about early on. But it's poorly implemented, and I think it's missing big components. I don't think there's enough emphasis on nosocomial viral infection and their importance in developing HAP. Routine NHS data suggests that there is significant variation throughout the UK, so there's certainly room for improvement in some regions and in some hospitals. And also, if you look at routine NHS data, you can pick the patients who are at significant risk, and you can start to use that to build prediction models to think about how we focus our resource on patients who are particularly in need of measures to prevent them developing HAP. So I'll stop there. Thank you very much. I've collaborated with the Advancing Quality Alliance and these key people who've helped work on this data, with Richard Jackson, who's an NIHR-funded senior statistician, and Katie Cawthorne, who is an academic foundation doctor. And if you want to collaborate to tackle HAP, please email me, and I'd be pleased to speak to you. Thank you very much.